All right, let's get going here. Somebody want to take this one?
I'll give it a go. All right, so here we have a shave of a papular lesion.
Good.
Mhm. I noticed that there's a lot of acanthosis or thickening of the epidermis. There's some like maybe parakeratosis or crusting at the top. The surface looks papillomatous. And then it overall looks pretty well defined. I was noticing the collarettes of scale kind of retaining all of it. So I favored neoplasm, likely
Good.
benign from this power.
Good. Excellent. And can you tell epithelial, non-epithelial?
It um looks like it could be epithelial or
Yeah, that sort of throws a lot of, I find a lot of residents get thrown off when I ask that question because it's sort of they think epithelium, they sort of think squamous epithelium. But basically, when we say epithelial, we sort of mean any structure that has got an epithelial differentiation of any kind, like follicular, uh, Eccrine apocrine is a type of epithelium. Obviously, basal cell, that's an epithelium. So it's basically just means any kind of structure that's got keratin in it at some level. So it's epithelial in a way. And so then you have to say, well, what kind of epithelium is it differentiating toward?
mm-mm.
Right, it's absolutely benign. And I agree, it is epithelial, but it's not typical squamous epithelium like stratified squamous like in the epidermis. It's got something else going on down here, doesn't it?
Mm-hmm.
Good. So
Mm-hmm.
what kind of epithelium do you think we're looking at here?
I favored more adnexal
Yeah,
follicular in
good.
origin.
Follicular. Follicular. Now that sort of gets, you think of the hair follicle, there's really three main parts of the hair follicle. But
Mhm.
then there's really, when you start thinking about it, there's some sub elements of the follicle too that things can differentiate toward.
Okay.
So if you're if this is follicular, which I agree it is, which part of the hair follicle do you think this is recapitulating here?
Okay. It could be the outer root sheath.
Good, good, excellent. It's the outer root sheath. So basically, where does the outer root sheath live?
Oh, that's a great question. Is it in the, I may get this wrong, and is it in the isthmus?
It's actually just beneath the isthmus. The isthmus is kind of the where the stem cells live, if you will. It's kind of where the bulge lives, and so that's where the cells kind of originate that then kind of repopulate the lower part of the follicle when the follicle goes through cycling. And so so the answer is sort of yes, because that's kind of where the stem cells live. But if you look at it at a normal hair follicle, the outer root sheath is in the lower part of the hair follicle. So you have the infundibulum, the isthmus, and then the inferior portion. So it's in that inferior portion, and it is on the outer side. And why did you say outer root sheath for on this? You're right. That's exactly what it is. But what was it here that made you draw that conclusion?
Um, the I think it's the edge of the palisading cells at the bottom just looked like a like the inferior portion of a hair follicle.
In what part? What's it does look like it. I agree. But what features that you're looking at right in this image here that tell you or make you favor
Mm-hmm.
that's outer root sheath, for example, versus the inner root sheath?
Could it be, well, here I'm seeing the basement membrane.
Yeah, this is the basal membrane of the structure right over here. I agree with that. And there's some.
Okay.
It's got a little. This is recapitulating the hair papilla a little bit right here, little blood vessels. But
Uh,
there's something right in this field that's classic for
oh,
outer root sheath differentiation.
is it the more clear cells?
Yes, good. The more clear cells, like right here, and those clear cells contain glycogen in them. So the next time you look at a regular garden variety hair follicle, take a look at it. And that's not really a very good one there, but look at a good hair follicle. This is maybe a follicle here, kind of cut in transection. You can see some of these cells are kind of clear. This isn't as good as you should be able to see. But you're right. That's the outer root sheath of the hair follicle that it's differentiating toward. And it
Okay.
overall looks kind of like a verruca in a way.
Mm-hmm.
So sure, you know the diagnosis. What is the diagnosis here?
Trichilemmoma.
trichilemmoma, or some people refer to this as a tricholemmal verruca because it looks kind of verrucous, if you will. Some people have lesions that clinically look like a classic wart, and you
Okay.
biopsy it, and it looks like this. So you're taking the board examination, and you see this. It's your slide. You look at it, and you think you know what the answer is, and you look down there, and they've got several things in there that might try to throw you off. What's probably the number one thing they're going to put in there to try to throw you off?
Besides a wart, perhaps a clear cell acanthoма.
They might, because it's got the clear cells. Now that usually looks more kind of like psoriasis, a clear cell acanthoma, so it doesn't really have the classic warty architecture. But what do you think what do you think clinicians are usually miss this for when they take a biopsy of it?
A basal cell.
Yeah, basal cell. So they'll probably put that on there. And, there might be a few people that look up here and say, well, it's kind of palisaded and, maybe there's a little tiny clefting here or something like that. And they'll just apply kind of partial criteria
Uh-huh.
and then they'll miss the answer.
Got it.
Good news is you would never do that.
Let's hope.
So good. Now, there's one final thing that
Mhm.
they might ask here. Maybe they think that every resident in the world is going to get this right. So they might ask, well, what syndrome is associated with this lesion here?
Mhm. A Cowden or
Yeah, Cowden syndrome. And that's a fairly straight, all residents at this point know that. So trichilemmoma, trichilemmoma verruca looks like Cowden's. And you make sure you know everything that they can get in Cowden's, all the different cancers they can get and all that sort of stuff, because they do like to ask some of those second order questions sometimes.
thank you.
Okay. Okay.
Good morning. I'll take this one.
Okay, good.
So looks like we have a shave of a neoplastic process within the dermis.
Good.
We have these islands of basaloid cells. Looks fairly like overall like pretty well circumscribed. So I was favoring more of a benign neoplastic process.
Okay, good.
And then going a little bit closer, there's a little bit of palisading, but not much in the way of clefting.
What kind of
And I didn't see,
differentiation do you think this is before we go to that level?
oh, say it again.
What differentiation do you think we're looking at here? So again, we have epithelial or non-epithelial,
So epithelial,
and then
um,
just like the last one, which epithelium do you think we're looking at here?
more like follicular.
Good.
Um,
Now, the last one we asked about is which part of the hair follicle is being recapitulated here? Which part,
uh,
in this case, do you think is being recapitulated?
like the hair bulb.
Good. The inferior portion, right. The very lowest part.
Mm-hmm.
Good. Very, very good. Now, where do you think these are actually coming from in real life? These little follicular structures here.
I'm not sure.
They're probably coming from the mantle zone, just like the last case. So that's kind of
Okay.
where the stem cells live. And so when they form these neoplasms, they're probably
Mm-hmm.
not coming from a hair follicle, the bulb of the multiple hair follicles forming this. It's probably coming from that stem cell area. You get a
Oh, I got
mutation,
it. Okay.
and then because those are pluripotential cells in essence.
Right.
Sebaceous gland, they can form an apocrine gland, they can form a hair follicle, they can form a tricholemmal follicle, a lesion like we just
Mm-hmm.
saw, they can form this lesion like we saw. So that's most likely where these are coming from. And
Mm-hmm.
that's why they don't all look like the textbook. They can all look a little bit different. Now you made a
Right.
couple other observations. So what's the main differential diagnosis here that you're looking at?
Probably basal cell would be the
That's
main
probably
thing.
the number one. Yes, that's probably the number one.
Mm-hmm.
We're gonna probe a little more deeply and have a couple of other things in a minute, but let's go to higher magnification. So what
Okay.
criteria are you using here to distinguish between a basal cell and a non-basal cell?
Sure. So I already kind of mentioned like, we're not really seeing the clefting. I also saw some horn cyst here, which generally won't be seen in a basal cell. And then
Talking
looking for
about
any
this
sort
area
of
right
like,
here? You're speaking of this?
yes, and I think there's a few more elsewhere as well.
Okay,
Um,
and down here, there might be one. Okay. Said something about
um,
cleft. Tell me what you mean when you say clefting.
so that kind of clefting artifact that you would get like along the edge of the kind of islands of basal cells or
Okay,
basaloid
good.
cells.
Good. What happens in a basal cell carcinoma is you're right, you get a cleft between the basal cell carcinoma itself and the surrounding stroma, which is usually more of a fibromucinous stroma. And this one's
Mm-hmm.
got a bit of a loose myxoid area to it, but in some
Right.
areas, you can see that it's a lot more fibrous, like up in this area. There's really very little mucin. And if you look at the stroma of the basal cell carcinoma, it's got a lot of fibroblast, mucin. It's actually part of the soil, if you will, of the basal cell carcinoma. And sometimes we'll even see a basal cell carcinoma where the little tumor island has fallen out, and we can suggest the diagnosis just looking at that stroma. This stroma looks
Mm-hmm.
completely different. This is more of a fibrotic stroma with collagen, with very little mucin, and it doesn't have as many fibroblasts. So there's no clefting between this stroma and the basal cell carcinoma. If there is clefting, it's like here. They're
Right.
cleft,
Yeah.
but notice how it's within the connective tissue,
Mm-hmm.
as opposed to being between the carcinoma and the connective tissue. So that's not an unequivocal criterion for diagnosis, because look over here, maybe you got a little bit of that, but that's a helpful finding if you see that. Okay, good. What else allowed you to favor the diagnosis of non-basal cells? So you get the little cysts. Sometimes you can see
Right.
that, but less common. The lack of clefting between the epithelium and the stroma, and the lack of the fibromucinous stroma, that's helpful. Anything else that helps you?
Perhaps like cellular atypia and things which you shouldn't really see in the trichoep.
Yeah, and there's one other thing that you can see, like maybe right here, that's helpful.
Oh, okay. I was having trouble for like a papillary mesenchymal body.
Yeah, they're not as great in this one as in some.
Yeah.
That's probably one here, a little abortive one. That's probably one there. So those are the things you do look for. You're exactly right. Some other things that you sometimes see, some calcification and little small cysts with calcium in them. Those are often seen more in desmoplastic trichoepithelioma than in
Hmm.
the garden variety trichoepithelioma. Now, once again, is there any syndrome that's associated with this lesion?
Brooks-Fiegler.
Um,
For trichoep,
yeah, that's one. I thought,
there's like a
yeah,
familial, I think, trichoep syndrome. Like,
I thought Brooks Spiegler was more cylindromas and spiradenomas. Maybe I'm wrong, but I
oh,
thought
it
that,
is. I just thought it also had trichoep. Maybe I'm wrong.
yeah, that's
Um,
more just kind of multiple familial
mhm.
trichoepithelioma that can be, it's autosomal dominant, and it's not really, I don't think they get any systemic manifestation associated with that.
Right.
But there's a couple other things. So just like the other one, you're going to look down and they're going to see things that you might have to choose from. So what else might they put on the board examination to try to trick you up here when you're making this diagnosis? So they put basal
Uh,
cell, obviously we've excluded that. What else might they put on there?
yeah. So I mean, kind of in the same realm, like a trichoblastoma would potentially be, like a deeper lesion.
Usually
Maybe,
far more cellular and all that.
yeah,
Thought it'd be a
right.
little bit unfair to include that.
Maybe like a MAC, perhaps, which would be like more infiltrating.
Yeah,
Um,
almost too easy, but they might put that in there. They
what
might put
else?
a couple of other things in there, possibly.
Hmm.
What about bird hog Dubay? Like
Oh, okay.
parafollicular,
Mm-hmm.
trichoepithelioma, parafollicular fibroma? What if that was down there? Why would you not choose that?
Hmm. I'm not sure.
Okay, well, the key to
Mm-hmm.
those kind of questions is you got to have in your brain a mental image. So you have to
Right.
to look at it and say, well, I know it's not that because it doesn't have A, B, C, D, and E. Those are usually little tiny papules, are usually the size of a fibrous papule. You'll see a tiny hair follicle that's kind of got
Okay.
a little abortive. It almost looks like something like this. And then surrounding, it's usually vertically oriented. And surrounding that, you'll see this perifollicular fibrosis, a little almost kind of an onion skin kind of perifollicular fibrosis. So I would encourage you to
Oh,
go
yes,
back
yes.
to one or two of those because they could ask that because that does look quite a bit different than this lesion.
Right.
The
Yeah,
number
with
one
kind of
thing
the,
they probably would put in there would be basal. So they wouldn't put something like just a benign
yeah,
follicular hamartoma because that can look a lot like this. Okay, good.
thanks.
Can you hear me?
Yes, loud and clear.
Okay. Okay, awesome. Okay, so here I see a pretty deep punch.
Okay.
And I think the thing that is most striking is just the significant amount of pigment in the dermis.
Okay.
And just because of the amount of pigment and not a whole lot going on in the epidermis, I thought of either like epithelioid blue nevus, or I know there's the melanoma of the animal type. I know that if you can't really distinguish between the two, they call it the pigmented epithelioid melanocytoma.
Okay, let's take a look at it. Is there anything else that this could be?
I mean, it could be a cellular blue nevus, but sometimes that doesn't have pigment, right?
Is it possible that maybe the pigment really isn't even melanin?
It is possible.
Good. So, they might do something like that to you on the exam. It's in the old days, we used to be able to we take a microscope and we take it there and you could actually rack down the condenser. And if it would be refractile, that would favor that it's hemosiderin versus melanin. Looking at this field, you think there's any chance that it could be something other than melanin?
No, I see lots of globules. I would favor melanin.
Yeah, it's really these are fine, delicate granules. And notice what am I pointing to right here, for example?
Like a spindle cell.
Yeah, like a dendritic or spindle cell lesion. And if this were something like iron or hemosiderin, then you wouldn't expect to see those delicate, elongated spindle cells. You'd see more larger siderophages. So yes, I agree. This is melanin. Now you mentioned a few terms in there. They're probably not going to get into animal type melanoma. That's more dermatopathology board, so you're not going to have to deal with that. And they certainly wouldn't give you a punch biopsy of something like this, if that was even in the differential, because that's obviously going to be that's like a sea of solid melanocytes. And you look at that and they can be surprisingly not super atypical, but you might see an occasional mitotic figure or whatever. So that's a more challenging diagnosis to make. But this does have features of the cells are characteristic of this entity here. So you pointed out they're kind of dendritic and they're somewhat spindle in some areas. I'm not sure they're as epithelioid and usually so-called, and they're also probably not going to get into pigmented epithelioid melanocytoma and that kind of stuff. That's too complicated.
Okay.
So if I showed you something like this, I want you to sort of think, it looks more like a cellular blue nevus or blue nevus, something like that. It doesn't
Okay.
have thermal involvement. It's got the spindle cell morphology, the dendritic cells. So this is a variant of blue nevus. Now, what is another pattern of blue nevus that we commonly see, even more common than this?
I know there's the deep penetrating. I don't know if it's more common or not.
Yeah, those are rare, actually. Those are much less common. But the most common type of blue nevus when you biopsy it, what does it look like?
It's just normally more in the superficial dermis, smaller.
Yeah, it's smaller. They have usually heavily pigmented dendritic melanocytes and a very sclerotic stroma. Sclerotic stroma. In fact, another name for that is that Dr. Eccrine used to try to promote years ago was a spindle sclerotic type of blue nevus. This one is called cellular blue nevus, but it's not really a very good name. The cellular really doesn't tell you very much. it's probably better to sort of describe the actual type of cells. And there's a kind of maybe more dendritic pigmented variant of blue nevus, something like that. But the most common type we see has got a really sclerotic stroma. This is a different variant. It's diffuse, extends deep, goes all the way down into the subcutaneous fat. Now, they might ask something, is there any syndrome that you're aware of where you can get a very prominent lesion like this, a lot of spindle cells, very heavily pigmented blue nevus, and blue nevi, by the way, most of the time, especially when they're like this, are congenital in nature. Is there any syndrome that you're aware of that might be associated with a lesion such as this?
I am not sure.
Okay, well, Carney's complex, Carney syndrome, they get like atrial myxomas, they get these kind of skin lesions, they can get blue nevus like cells, it can even get into the CSF and the spinal column. So that's something that I would recommend at least boning up on that syndrome, and they get these heavily pigmented lesions like this in their skin. So that's one of the things that you can see, and they're often congenital type blue nevi that they can end up getting in that situation. So that's called Carney's, C-R-E-Y-S.
Okay, thank you.
Good. Well, let's give this one a go. Switching gears a little bit here.
Okay, I can do this one. So we have a punch here. Looks like we're dealing with a rash. Thought this was from April.
Rash, I kind of rash always make my skin kind of crawl a little bit as a dermatologist. I mean, everybody says rash, but to me, rash is more of a layman's term, like mold. It's like that. I always say cutaneous eruption or inflammatory skin disease, something like that. We got to sound a little bit more. We have to have some way to kind of speak in our own little lingo that the patients can understand. So.
Okay, so it looks like we're dealing with an inflammatory skin disease here. Looks like so from this power, we also see this dense infiltrate along the DEJ, looking like a lichenoid infiltrate. So
okay, excellent. I agree with you. Very, very good. Lichenoid dermatitis. Okay. What kind of cells do you think we're looking at here?
So I think they're predominantly lymphocytes.
But wouldn't that be darker? The cells, wouldn't they be darker and more jet black at low magnification?
Yeah, I guess so.
Yeah, they usually are. Take a look at lichen planus. You didn't think this was lichen planus, did you, by chance?
No, I did not.
Okay, next time you go back and take a look at a picture of lichen planus at low power and put this next to it, and you're gonna say, I get it. I see what he's talking about. Those definitely are not lymphocytes at low power. But there were lymphocytes.
Maybe some histiocytes. I didn't think it was.
Some of them probably are histiocytes. Yeah, they're pretty pale. Yeah. If they were lymphocytes, I think you should think lichen planus here.
Yeah.
Okay. So we got a lichenoid infiltrate that's got some cells in it that are not all are lymphocytes. And what about the epidermis?
So the epidermis has some irregular acanthosis. The rudi are pretty irregular, jagged somewhat.
Psoriasiform. It's irregular psoriasiform hyperplasia with a band-like infiltrate, lichen infiltrative cells. Some of them are calling it lymphocytes, but they're definitely not all lymphocytes. They may be histiocytes. And what about the cornified layer?
The cornified layer, I thought it was pretty normal.
There's something going on. There's certainly not. Is that normal? I guess if it's palm or sole, maybe it could be.
Yeah, I was thinking it was palm or sole.
Yeah, it probably, okay, maybe palm or sole. I was thinking about it from the trunk, and then it just kind of maybe they're rubbing it, or it's got some parakeratosis a little bit, but it could be normal if it's palm or sole. Okay, and it's mostly superficial, right? There's really not a lot of deep infiltrate. Maybe a little bit here, but mostly superficial. Okay, so any differential diagnosis of low power?
Yeah, this one's a bit tough for me. I was thinking there's maybe also some
That's okay.
plasma
That's
cells.
actually fine, believe it or not. You can come up with a differential of maybe 4 or 5 things. You're probably
Yeah,
not
so I was,
the diagnosis of low power like this. But that's okay.
yeah. I was thinking it could be maybe like syphilis. Also thought like I was thinking of things like lichenoid things on acral skin. So I was thinking maybe also like lichen striatus, but again, you didn't see like the
Good idea.
deeper.
Very good idea.
Um,
Yeah, you lichen striatus, you should like to see some inflammation around the nexal structures like the sweat glands deep, but so that's a possibility.
mhm.
Anything else?
Also thought about lupus as well.
Not a bad thought.
Um,
Put that in there. Usually more
yeah.
lymphocytes, but anything else?
I guess you could also consider, I mean, less likely, I guess, graft versus host can give you a lichenoid infiltrate. But I think
Okay.
those are also mostly lymphocytic. I don't know, maybe also EM could also give you, I saw a couple of dyskeratotic cells, but not many
Fact,
for
usually
EM.
recommend infiltrate. Um,
Yeah.
there's one that you probably aren't going to think about it, but at least I'm going to mention it to you. It's notice that some of these cells are in the epidermis. Warren J. Collop disease, and there is a form of granulomatous Warren J. Collop where you get histiocytes in the infiltrate. So basically, that's mycosis fungoides. It's just purely in the epidermis for the most part, sucking it into the epidermis. It doesn't go anywhere else. It's usually just, it's often on volar skin too. So that'd be something to think about. Maybe Langerhans cell histiocytosis. Maybe throw that in there because they're clearly not all lymphocytes. So those are just some things to think about. Let's go to the highest magnification here. And did you notice anything here now that allowed you to make a more definitive diagnosis?
Um,
I'm giving you a little help here.
let's see.
What are these cells here? That's as high as she'll go, but
Are these plasma cells?
plasma cell, very good. Here's the nucleus that you can't really see the clock face chromatin, but you can see the paranuclear little clear area there that's loaded with immunoglobulin. And then here's a plasma cell over here. So there's a lot of plasma cells. And you're right, these cells up here are histiocytes. Okay. And so we talk about histiocytes predominating in an infiltrate means that it's granulomatous. Okay. Would you characterize this granulomatous inflammation as being sarcoidal or palisaded?
Doesn't really look sarcoidal or palisaded
No,
to
it
me,
doesn't.
but
You're right. Exactly. That's the observation. Syphilis tends to form sort of poorly formed granulomatous inflammation like this. So this is syphilis. Okay. Now notice this pattern is superficial perivascular, basically psoriasiform lichenoid. The most classic pattern is superficial and deep psoriasiform lichenoid dermatitis. I've seen some that looks almost exactly like lichen planus. I've seen some that looks like pityriasis lichenoides. I've seen some that looks like a viral exanthem. I've seen syphilis that looks like psoriasis. So it truly can mimic just about anything. We have a lot of sayings in medicine, and a lot of them are sort of partially true, but one that is true is that syphilis is the great imitator, and it really can look like a lot of different things here. So I do want you to think about those other items in the differential diagnosis. The board would never give you this without like a special stain for spirochetes or something like this and just expect you to get this. But if you recognize this pattern of poorly formed granulomatous inflammation with plasma cells and the psoriasiform lichenoid infiltrate, and it really is lichenoid, it really is obscuring the DE junction here in several areas. That's a very important clue to the diagnosis of syphilis. It's one of the histologic patterns that we see with syphilis. Good. All right, any questions? All right, let's move on to another one.
I can take this one.
Good.
So yeah, this looks so yeah, has a punch maybe from the face or the scalp, a place that has like a lot of sebaceous gland and hair follicles.
Do you
At
favor
low,
the scalp or favor the face more
I
based
think I
on?
favor the face more because of I'm seeing hair follicles and some sebaceous glands. So I favor the face.
Well, you do get sebaceous glands on the scalp, but usually the face has got a lot more than this. So it's probably the scalp,
The scalp.
but that's okay. You're right. It is a
Okay.
hair area. It's either going to be one of those two. So that's good.
Okay. In terms of the pattern, it looks inflammatory to me. At low power, I see like a superficial perivascular inflammation. I also see periacne inflammation. I see a lot of inflammation around the hair follicles and also see some inflammation in the periacrine glands. And the inflammation goes deep to me. Like I also see some deep perivascular inflammation, even going down to the circuit.
Good. Superficial indeed. What kind of cells do you think we're dealing with this time?
I'm favoring lymphocytes.
Yes. So remember the last case we just saw, those cells at low power look kind of clear. These look really dark. So you're right. These are lymphocytes. So the
Yeah.
superficial deep lymphocytic infiltrate that's also perifollicular. Now let's say this is the scalp and it's not the person's face. What do you think that scalp looked like right here?
It's going it's going to have like inflammation in the scalp. There might be some alopecia.
Good. Very good.
Depends.
Excellent. It's going to be this normally we would see about 7 or 8 antigen follicles rooted in the fat. In this biopsy, we only got 1. This one's miniaturized. There's one way up here. There's maybe some areas where there used to be follicles that they're not even there anymore. So yes, this is going to be alopecia, an inflammatory alopecia. Okay, good. So when we're dealing with alopecia histologically, we then ask ourselves, where's that inflammation located? What type of inflammation is it? You've already said it's lymphocytic. And then is this going to be a permanent alopecia with scar or a non-permanent alopecia that could come back if you gave the person a JAK inhibitor or something like that?
Yeah.
So what do you think here? You think this is more permanent?
I
Never
think
going to come back?
I think it's probably more permanent.
Yeah, I totally agree with you. Let's go to
Yeah.
even higher magnification and
Yeah.
see if we can figure out see if there's anything else here that helps us.
Yeah.
What's
I
going on
see
here?
some fibrosis.
There is some perifollicular fibrosis. I agree with you.
Yeah.
Here's fibrosis that's kind of destroyed a follicle right here, right?
Yeah.
And what's this material here?
Oh, I see. I see mucin.
Good. Very
Yeah.
good. So
Mucin.
what's the most likely diagnosis of this alopecia?
Yeah. So I favor Discoid lupus for this.
Okay, good. You're correct. Now, one thing that's interesting about this case of lupus, what's a little bit unusual about this lupus case here?
Yeah, it was unusual because I didn't see a lot of epidermal changes. I didn't see changes in the basement. Man, there was no vacuolar changes in the basement in the TJ.
Excellent. Very good. That's exactly right. Normally, when you see like chronic discoid lupus erythematosus, you'll see effacement of the epidermal reedy. The epidermis gets very thin, get a thick basal membrane zone, get vacuolar alteration. So we really don't see that here. So it's a little bit of an unusual variant of lupus. Is there any form of lupus that you're aware of? And this is a more sophisticated, difficult question. But is there any variant of lupus that you can see that can give you this pattern where you don't get these changes up here, yet it's still lupus alopecia?
Mm, I know I consider the possibility of ge of ge ge has now lymphocytic inflammation of the skin, but that is more that will tend to affect the face more than the scalp.
It's kind of a tough question in a way, but
Yes.
sometimes patients with systemic lupus erythematosus, SLE, got known SLE, they've got a positive ANA, positive double-strand DNA, they're sick, they've got renal disease, et cetera. They'll have a flare of their lupus, and they get an acute alopecia areata-like inflammation with their scalp, and the biopsy looks more like this as opposed to classic chronic discoid lupus erythematosus. So they get a diffuse alopecia as opposed to the patchy alopecia that we see that gives permanent scarring that never comes back with patients that have got the chronic discoid lupus erythematosus. So this is really more possibly like that pattern rather
Okay.
than chronic discoid LE. Now this may be a little bit more chronic than that, but the fact that we don't have any epidermal involvement tells me that this inflammation is targeting the follicles more than it is the epidermis and the follicles. So it's a slightly different pattern than most cases of DLE that you noticed.
Okay.
We sometimes see the differential diagnosis of lichen planus and lupus erythematosus clinically. So the dermatologist will biopsy person with alopecia, and they send it as LPP versus DLE. And occasionally we see this pattern. And so we sometimes call that maybe an overlap between lichen planopilaris and discoid LE. They can sometimes look kind of similar. You can see lichenoid lupus erythematosus on the skin that can look a lot like lichen planus also. So just realize that there can be overlap sometimes between those two. I don't like lichen planus here nearly as much because look how deep the inflammation is going. And lichen planus just likes this area right here. It's like it's just got a love affair with the isthmus of the hair follicle. That's where the inflammation of LP goes. That's where the inflammation of central centrifugal alopecia and frontal fibrosing alopecia goes. That's why I think that they're kind of all related, because histologically they all look very similar. But DLE or lupus alopecia goes deeper. It goes way down in here, and it's got the mucin that we saw. So good. This example of lupus alopecia, and possibly this sort of systemic alopecia.
Thank you.
You're welcome.
Hello, I can take this one.
Okay, great.
All right, so here we look like we have they're like a saucerized shave of an acral site. And
It's a shave.
okay, maybe a punch that's broken into pieces.
Yeah, I think it's probably that. They might
Okay.
be trying to do incisional biopsy or something. So it
Okay.
goes
Of an acral site. And then you see these like dermal basophilic clusters here. So perhaps of like some like indurated plaque or a subcutaneous nodule that was biopsied.
okay.
And favoring more inflammatory over neoplastic, given all of this like dense infiltrate.
Okay, good.
At this
It's kind of
power,
funky in some ways because it's sometimes they'll show something like this, and it's maybe got a pattern that you've never really seen exactly before.
Mhm.
That would kind of bizarre. I mean, I remember when on my board exam, and many years ago, they showed a really funny picture of Kaposi sarcoma. It was really in a weird way that they presented the picture, and I looked and said, "Man, I've never seen it look exactly like that." You still kind of recognize what it was. So sometimes you'll see something in here and say, well, I've never really seen exactly that. And they may put some weird answer choices in there that kind of throw you off. So make sure you just kind of apply your criteria as best as you can to go through it systematically and don't just sort of jump to possibly some kind of funny conclusion and say, well, gosh, I don't know, and it confuses you. So that's important. So you're right. This is inflammatory. What's the pattern of the inflammation here?
I would say like looks granulomatous.
Okay, it is granulomatous, but the pattern of that granulomatous inflammation, what kind of, would you call this superficial perivascular? Would you call it more nodular and diffuse?
Yeah, more nodular and diffuse.
Yeah, you've got these nodular aggregations, these cells here, and it goes all the way from the top of the specimen down to the bottom. So you can imagine what this thing looked like clinically. Okay, so it's granulomatous. We know that there are 5 main patterns of granulomatous inflammation. Which pattern are we looking at here?
Let's see. Would it be like caseating?
Well, you've got neutrophils here, right?
Right.
And histiocytes. So what do we call that pattern?
Like foreign body?
Well, foreign body is one pattern, but there you actually see a foreign structure in there with the inflammation. But when you have neutrophils plus histiocytes, when you have neutrophils only, what do you call that?
Not suppurative, right?
Yeah, suppurative.
Okay.
So if you have suppurative with granulomatous, it's suppurative granulomatous. And you say, well, suppurative granulomatous inflammation, what are the things that cause that? Where do you see suppurative granulomatous?
Like infections.
Yeah, infections are one very common setting. Ruptured folliculitis, ruptured cyst, hidradenitis suppurativa, actinomycetoma nuki, all those things, acne, all of those. And then other things like this thing. What is this you're looking at right here?
So this looked like the Splendor Hopley phenomenon where you have that like basophilic center with an eosinophilic rim. But essentially like these maybe sulfur granules is what I was thinking of like the collection of.
So you're thinking it's a granule.
Mhm, mhm.
Splendor-Hopley phenomenon, it can be seen in association with grains and infectious agents. Sometimes it can be seen even when there's not any infectious agent in there. So it's sort of almost a reaction pattern of protein to generated collagen, often with organisms. So this is one of those good old show you this, expect you to sort of see it, recognize it, and then they're going to give you some choices here. So what grain are we looking at here?
Well, so I thought about basically like bacterial versus fungal organisms, and I didn't
Good,
see.
that's what you should think about, exactly.
Okay.
And okay, so based on this is, I would say this is diagnostic here. Which of those two are you going to fall into?
I was going to fall into bacterial.
Which bacterium?
Well, I was thinking of Boitromycosis, and I know staph is the most common cause of that.
Okay, now they could throw that on there.
Mhm.
Why is that not so good here in this grain that we're looking at here? Why is Botriomycosis not the best answer? This is a really sophisticated question that I doubt seriously they might. It might get thrown out because everybody might miss it, but why is this not great for Botrio? There's 2 reasons, but there's one main reason.
Is it because it looks like maybe more filamentous than like the gram-positive
Yes,
cocci?
yes, exactly. Botrio is gram-positive cocci. So you're going to see round organisms there glued together, growing like a column. Here, yes, we do have filament. This is almost like a spider web here. It's like cotton candy. So these are all, so what organisms are these?
You could think of like Actinomyces has that
Yeah,
filament.
these are gram-positive rods. So this is a gram-positive rod disorder. Actinomyces is a gram-positive rod as opposed to gram-positive coccus. And some of these little sort of linear sort of structures at the periphery, that probably is that Splendor-Hopley phenomenon, but they tend to give you this linear kind of morphology here when it is actinomyces.
Okay.
I'm not sure why that is, but that's fairly repeatable. But this is what is like a mat. This is like a mat, basically, a gossamer mat-like web of gram-positive rods here, forming a colony in the skin. Multiple colonies, actually, in this case. Now, if this were something like a fungal lesion, what would you see?
You would see like the hyphae and branching.
You see the hyphal elements, and usually the grains, like in a maduromycosis and that kind of thing, the grains of a fungus, they can be multiple different colors. They can be red, they can be black.
Yes.
So there's several different colors of those. I would recommend boning up on those. But you'll see the hyphal elements, and especially if it's like one of these maduromycosis lesions that's got a brown grain, you'll see the dermatiosus fungal organism. It's almost like lots of copper pennies, and they're just kind of clustered together. You'll see that in the grain itself. So you should be able to tell the difference between an Actinomyces grain and one of those grains.
Okay.
And what's the only other disease that we see in dermatology that gives you grains like this? Other than Botrytis, Actino, Maduro, there's one more.
Nocardia?
Yes, nocardia. Those grains usually don't give you this many organisms, this filamentous. When you see those, they just kind of almost look like a little pink glob of protein. So this looks really good for Actinomyces. It's one of the best ones that we had here in a long time. So it's really a good example of that. Okay, great. And they might ask you that. I mean, they like to hit infectious disease because there's no controversy. I mean, once you put something like that on there, you can prove that it is what it is. So you're probably you could get that. That's potentially fair game.
Thank you.
You're welcome.
I can do this one. So it looks like at low power we have a punch here. What stands out to me is kind of this sparseness of the collagen here in the dermis. It looks like there's all this instead like grayish material.
Good. Good.
It's
What do we call that general process when you see what you just described right there?
I'm not sure the specific name.
Deposit.
Okay, like a deposition.
Yeah, deposition disorder.
Okay.
So it's a little bit different. We talk about inflammatory and neoplastic, and so this is a different ball game slightly. It's a deposition disorder. Something's come in. It doesn't normally belong here. It's come in and it's deposited. Now, that may not really be the way that this happened this time. So it could be that it really is a low-grade inflammatory process and it produced all of this material. So that's another possibility. But generally, when you see something like you just said, when the collagen is no longer there and something is there instead of it, think that it may be a deposit. So if it's a deposit, then you want to ask yourself, well, what is that stuff that's deposited there?
And I thought it was mucin. That was
good. You're exactly right. It is mucin. And there's a little bit of a sparse infiltrate here. Let me call you back. I'm right in the middle of this conference. I'll call you in about 10 minutes. Yeah, so there's a little bit of an inflammatory reaction, but it's minimal. Minimal. And you're right, it is mucin. Very, very good. Anything else it could be besides mucin?
I guess you could think of maybe like solar elastosis, but it's pretty extensive for that and deeper.
Good. You basically reject that. There's actually no fibrils or anything like that. And notice how it's sparing the papillary dermis, which would be kind of funny for that, right? But yeah, that's one thing. Anything else that can look like mucin sometimes, bluish gray like this, that actually isn't mucin? There's two things.
I'm not sure what would.
One is extracellular lipid sometimes.
Okay.
So of course, if you see somebody that's got like an eruptive xanthoma, they get massive triglycerides and it deposits the skin so rapidly that it's no longer within any cells. So that's one that can look like mucin sometimes. I agree this is mucin. The other time you can get this is sort of massive edema. Patients that have like horrible lymphedema, or they get metaphyma, that sort of thing in the face, Morbin syndrome, and they just get massive edema. That can sometimes give you this bluish gray color, and some of that probably is mucin in there also. But you're right. not too many things will look like this. Okay, so what's your differential diagnosis here?
So at the top of my differential, if anatomically it fits, would be pretibial myxedema.
Good.
I would also think of other mucinoses like scleromyxedema or scleroedema.
Okay, now let's talk about those two. Would you ever get this much mucin in scleroedema?
I think you could in scleroedema.
Not really. Usually what scleroedema is, it's massive thickening of the collagen.
Mm-hmm.
And if you see mucin in there, it's just kind of between and among collagen bubbles. There's not a lot of it in there. So you would never get a massive lake of mucin like you would see here in pretibial myxedema. That is the diagnosis, by the way. So you're right. But there's a couple of other things. Now, what about, you said scleromyxedema? Is there a variant of scleromyxedema where you can get pretty significant quantities of mucin like this there? There is a type that you can see in that situation.
Is it the lichen scleromyxedema? I'm not sure.
Okay,
Yeah.
good. It's never a bad idea to at least give it a guess. That's a try, but it's actually the papular mucinosis form.
Okay.
So if you look at the papules, you'll biopsy those papules, and sometimes you'll see the whole dermis is replaced by mucin there with the fibroblasts. So you can see it there. Are there any other conditions where you can get massive deposits of mucin like this, other than pretibial myxedema? You know the answer has to be yes, or I wouldn't have
Yes.
asked.
Yes. I think you could.
There's not too many others, though, which is good news.
Yeah.
But a couple you should at least know about.
Like REM, like retained erythematous
You
mucinosis.
get quite a bit of mucin in REM, but usually that kind of looks more kind of like tubin LE. You'll get the lymphocytic infiltrates, and you'll get mucin in the dermis, but you'll still have plenty of collagen in there. Same thing with GA. You can get quite a bit of mucin in that too, but you'll still get the histiocytes and the palisaded pattern. So you usually don't get the sea of mucin like you see here. But there are a couple of other diseases. Lupus erythematosus.
Mm-hmm.
There's a type of massive cutaneous mucinosis that can be seen in SLE. Sometimes your biopsy looks just like this, interestingly enough, and sometimes dermatomyositis. You'll see these patients come in with a big boggy lower eyelid that looks like they're bullous, and you biopsy that, and it's got tons of mucin in there. So you can see it in dermatomyositis on occasion also. But not too many other diseases will give you this massive mucin like this. It's so-called, other thyroid disorders other than pretibial myxedema. Sometimes you get lots of mucin. If you biopsy somebody who's got cutis verticis gyrata, sometimes they can get a lot of mucin there, but never really quite like this. So this is pretibial myxedema. Now, the other thing you have to think about are neoplasms, where you can get lots of mucin. So, for example, a myxoid lipoma, sometimes you can see lots of mucin there. Usually you get you can see that there are fat cells in there also, and you'll get some spindle cells. So that'd be a little bit of an unusual situation there. And then just a cutaneous myxoma. Sometimes you can see massive. And we talked about atrial myxoma and Carney's complex. They can sometimes get cutaneous myxomas in that syndrome as well. So this is the differential diagnosis of mucin. Now, there's one cutaneous neoplasm that we see a lake of mucin associated with little islands of epithelial cells within that lake of mucin. Do you know what that tumor is?
I don't specifically.
Mucinous carcinoma of eccrine glands.
Okay.
So remember that. And mucinous carcinoma, breast metastatic mucinous carcinoma, they get lots of mucin, a lake of mucin, and then they'll get these little aggregations of epithelial cells within them. So remember that one also.
Thank you.
You're welcome. All right.
See, I could do this one. So it looks like maybe like a giant punch that kind of went down to the fat or an excision.
Or maybe even an excision, possibly.
Yeah, and two things, epidermis looks pretty good, and like it looks like the main things that kind of caught the eye are like these almost eccrine appearing cells in the mid-dermis. And then right below that, there's a collection of what appears to be vessels
Good.
with lots of blood filled within them. And so a couple
Is this epithelial or non-epithelial, an inflammatory
epithelial.
plastic process? What do you think's going on here?
It looks neoplastic.
Yeah, or maybe if it's not really a true neoplasm, sometimes
Yeah,
we have a term for that. What do you think that might be?
like a hamartoma.
Yeah, yeah, good. Are you aware of any hamartoma that might look like this?
Maybe like just given that there's eccrine appearance and an angiomatous appearance. Eccrine angiomatous hyperplasia or hamartoma.
Good, excellent. That's what it is. Um, Somebody that named this was smart because they basically gave it a name that's descriptive of what's going on here. Eccrine angiomatous hamartoma. And now these beautiful example of eccrine glands here. You see that you've got the clear basophilic cuboidal cells here in this eccrine unit. And here you've got the clear cells that got the glycogen that are actively mitotic, they're metabolically active, trying to reabsorb all the ions. So these are ATP actively functioning cells here. These are probably more of the kind of the sustentacular cells that are lining the eccrine gland a little higher up. So basically, a nice example of eccrine. Notice the mucinous stroma that the eccrine cells are embedded in. And then we've got the angiomatous component here. So this is sort of almost sort of like one of those gee whizzer cases just to show you that you probably have never seen one of these except maybe in a textbook. I doubt seriously very many of you have seen one of these clinically. They're pretty rare, but this is what they look like when you see them. They're usually on usually kind of acral skin. This doesn't look like it's on volar skin. It probably maybe it's like on somebody's arm, usually the location. They're often seen in children. Sometimes they might be a little bit slightly uncomfortable. They're not one of the classic painful lesions, but it's a beautiful example of that. So I'm glad you got that correct. I don't think if they're going to show you this, it's going to be something like this. It's going to be pretty straightforward and pretty classic. So that's good. All right. Any questions about anything? We didn't get through all of them, but I think we covered some good information today. Maybe we'll put the ones from 9 and 10 on next week because they're good cases too, or next month rather. So I hope you guys will sign up for the business session and listen to it. I think it'll be valuable for you. I mean, I can tell you, I wish somebody had given me that when I was a resident years ago. So sign up for it. It's free. It doesn't cost you anything. You can listen to it at your own leisure. You can listen to it 20 times if you want to. And if you ever need any services, the guys that are donating their time, make sure you give them a call. So we will see you guys next month.
Thank you.